Dr. Donn.
Thank you. So those are my disclosures, which there are none. So this case is a 28-year-old Thai male from Isan who's working as a sex worker in Pattaya for 2 years. He said he usually, but not always, used condoms for anal sex with clients and casual partners. He had substance abuse once or twice a week, including alcohol, up to 5 or 6 drinks, used poppers, and crystal methamphetamine by inhalation. He did not smoke cigarettes. He was otherwise in good health, no medical conditions, and was not on any medications. He had an HIV antibody test, which was non-reactive. So he was given a prescription for PrEP with tenofovir FTC. This was done at a local NGO in Pattaya. So the first question for voting is, so if taken daily with good adherence, the PrEP will decrease his risks for HIV infection by how much? So I don't know how we do the voting. Do I have to push something? Just go down one. Oh, there it is. I got it. I just go forward. C, 86%. That's good. That's a good guess. Let me see. But actually, it's not correct. The correct answer is D, actually. And the key here was we said if taken daily with good adherence. So then the efficacy is much higher. So we have a lot of evidence about PrEP efficacy. The first evidence came from the IPREC study, of course, which had a clinical research site here in Thailand, in Chiang Mai. That showed a decrease in HIV prevalence or HIV incidence of 44%. So of course that was a clinical trial that was placebo-controlled, and we didn't know if PrEP was efficacious or not at that time. So during IPRECs, people were given a pill, and they said, this pill, it may be nothing, it may be placebo, it may have active ingredient, and if it has active ingredient, the active ingredient may do something or it may do nothing. We don't know yet. So it turned out in IPRECs, actually, people only took the medicine about half the time. The 86%, we've already heard a couple times this morning, comes from the PROUD study in the UK, and that did show an 86% reduction in HIV incidence. In that study, there was only 2 people in the PrEP arm who were on PrEP who got HIV, and if you read the paper, both of those people were not taking PrEP at the time that they got HIV infection. And so it turns out in both IPRECs and PROUD, and most other studies that you read about, there are people who get HIV infection who are randomized or put into the PrEP arm, but the people who get HIV infection when they're in the PrEP arm, for the most part, are not actually taking the PrEP for one reason or another. So we know from data from the IPRECs where they actually did blood levels of people in the different arms of the study and PK studies that if you take the PrEP 7 days a week or close to 7 days a week, actually your reduction in risk for HIV is going to be at least 99%. So this is question 2. So he was just given a prescription for PrEP. So when should the PrEP user return for this next visit and the next HIV test? So we will start the, okay. Okay, so most people said 3 months. A few people said whenever, but, and then there's always that one person who votes for the answer that's not even available. So actually, the correct answer is 1 month. So most PrEP implementation programs these days, after the first dose, after the first prescription of PrEP, we'll have people come back for 1 month. So we'll just give 1 month of PrEP the first time and then have them come back in a month. And the reason for that is because of the risk for HIV infection before starting the first dose. So we know that the HIV serologic tests, the standard HIV antibody test, it can take 2 to 4 weeks for those tests to become positive after somebody contracts HIV infection. So we cannot say if somebody has a single negative HIV antibody test, we cannot say 100% with 100% clarity that that person does not have HIV. So that's why we have them come back at 1 month to repeat the HIV test again, because if they did have HIV infection before starting PrEP, by that 1 month time period, the HIV serologic test should become positive. At that visit, we can also ask them about if there's any side effects to the medicine, any intolerance to the medicine, and then we can continue in counseling about adherence to the medicine and about risk reduction. So he came back 5 weeks later, had a repeat HIV test that was also non-reactive. He said that his adherence to PrEP was good. He reported missing only about 3 doses of PrEP per month. He felt well, he had no side effects from the PrEP medicine. He said he did have condomless, insertive, and receptive anal sex with a foreign male client during the first 1 to 2 weeks that he was taking PrEP. And he said all other anal sex episodes during the last few months were with condoms. So at that point, he was given a refill of the PrEP medicine for 3 months. So after that first visit for 1 month, then we can give PrEP for 3 months at a time and have them repeat the counseling and antibody tests every 3 months. So this particular client, after 8 weeks of PrEP use, he went to another clinic to screen for an enrollment in a research project. He said he continued on PrEP with good adherence, had no symptoms. They did also repeated the HIV serology. This was a different test, but it was also non-reactive. But for this particular research project, they also screened for a NAT test. So a NAT is the nucleic acid amplification test, so very similar to a PCR test that directly detects HIV RNA, and that test came back positive. And the result, it was from the same specimen on the same day, but it took 2 days to get the result back. So at that point, the clinic called him to inform him of the positive NAT result. He was advised to stop taking the PrEP, and then he was referred for evaluation of acute HIV infection. So he came in for that evaluation 2 days later, so about 4 days after the first negative test at 8 weeks, and this was 40 hours after stopping, or after his last dose of PrEP. And we can see that his serology here. So just within those 4 days, remember 4 days earlier, his HIV antibody test was negative. But within those 4 days, he actually seroconverted so that his 4th generation and 3rd generation antibody tests were reactive at that point. He had a 2nd generation antibody test, which was non-reactive. You can see his P24 antigen was positive. He had a Western blot that was still negative at that time. His quantitative HIV RNA was 116,000 copies per ml. His CD4 count was normal, although his CD4-CD8 ratio was a little bit low. And for this client, we were able to take a hair sample from him and send that to San Francisco, where they can actually measure the PrEP drugs in the hair. So when you get a hair sample like that, it's usually taken the 1 centimeter of hair that's closest to the scalp, and that amount of hair gives you a sort of an idea of what the PrEP adherence was during the previous 6 weeks. So those numbers there don't mean much, but the lab tells us is that the level of tenofovir and FTC in his hair samples were consistent with daily dosing of PrEP within the previous 6 weeks, which was also consistent with what he said. He said that he was taking it, maybe missing 3 doses a month, so fairly good adherence. We also did a tenofovir level in the plasma, which you can see there was 25 nanograms per ml, and that is consistent with taking the last dose of PrEP, last dose of tenofovir within the last 2 to 3 days. So that was also consistent with the history that he was taking PrEP up until 40 hours before this visit, when he was called and told about the positive test and told to stop taking PrEP at that time. And just a quick word about the different generations of antibody tests. So the older generation, the second generation tests, those detect anti-HIV IgG, which is of course a little less sensitive than IgM. So the third and fourth generation tests will also detect IgG as well as IgM, and of course the IgM will be present in the blood before the IgG. And then the fourth generation tests can test both for anti-HIV antibodies and for the P24 antigen as well. So the generations of the test is also tells us how sensitive they are. So the fourth generation test would be the most sensitive test, the third generation would be a little less sensitive, and the second generation would be less sensitive than that. So now we come to our next question. This one is a little tricky, so I don't know if people will know this one. So during acute HIV infection, we have 5 Fiebig stages, and those are defined by the evolution of serologic markers, including the HIV antibody, the P24 antigen, and the Western blot. So what Fiebig stage would this patient be in now? I think I can give you those, the serology. So just to remind you what the serology was. So if we can do if you can vote now, we can do the timer. Can we do the timer for the voting? Mm-hmm. So the choice is 1, 2, 3, 4, 5. Okay, so most people said Fiebig 1, actually, which this person was not in. Actually, the correct answer is 3, or C. Yeah. There. And this graph, which you'll see again in another talk tomorrow, shows us how the serology evolves over time. So, and basically the 5 stages are the stages at which we see different serologic markers appear after acute HIV infection. So in stage 1, we can detect HIV RNA only in the blood. So there's no antibody production, no antigen that we can detect yet as well. So that's the first, so the HIV RNA is the first stage that we can detect from HIV infection, and that probably occurs about 5 or 10 days after infection. In the next stage, we see the P24 antigen, so that's Fiebig stage 2. In stage 3, we see the IgM antibody, but the Western blot test is still negative. And in Fiebig 4, the Western blot then has some bands that are positive and some non-reactive, so it's an indeterminate Western blot. And then the 5 is a Western blot missing one band. So this patient, because we said that his 4th generation and his 3rd generation antibody tests were positive, and his P24 antigen was positive as well, but the Western blot was negative. So that means he was a Fiebig stage 3. And these stages, you can see, they don't last very long. Each stage can be only a few days up to a week or so. And people will go through all these stages in about 1 to 2 months after acute infection. So this patient had a genotype, was sent for resistance, and just like Malaysia, it takes 2 to 4 weeks to get the result back. So while we're waiting for the result, we decided we're going to start him on ARV. So this is the question. So, knowing that he was on PrEP and became HIV positive, but we're not going to get the genotype back for a while, what ARV regimen would you start? So we have TDF, FTC, efavirenz, just kind of standard first-line regimen in Thailand and the region, or we can change to AZT 3TC efavirenz, AZT 3TC lopinavir, abacavir 3TC dolutegravir, which is Triomec, or E, I don't know, I'll wait for the genotype result. So let's vote on that. Okay, so evenly split between 1 and 4. And actually what we did in our clinic was neither one of those. So we went for option C, which I still think is the best option. So option 1, the TDF, FTC, efavirenz, that's not a good option because we know that he was already on, he was on dual therapy for HIV at the time, either when he became infected or before he became infected, but we know that he had HIV infection and was taking dual therapy, and we know that that gives you a very, very high chance for resistance. So we really want to avoid the drugs that he was taking, in an ineffective ARV regimen, basically. So I would recommend not using TDF and FTC as a first line for this patient. The other thing is about efavirenz. Efavirenz has a very low genetic barrier, so if he does have resistance to the NNRTI drugs, we'd like to pick a third drug that has a higher genetic barrier to resistance. So for the second option, actually AZT is a good option because it should be active against a virus that's resistant to TDF. But the latest research I've seen is about a 5% risk of transmitted resistance to the NNRTI drugs. So given that risk and the low genetic barrier for efavirenz, probably be better to choose a different third agent. So we did go for option C in this patient, AZT, 3TC, lopinavir, basically because it avoids the drugs that you might be resistant to, and then lopinavir, ritonavir has a very high genetic barrier to resistance. And transmitted resistance to the PI drugs is quite low in Thailand. So D might be a reasonable option in some cases, but there is higher cross-resistance between abacavir and tenofovir than there is with AZT and tenofovir, particularly the K65R mutation, which is common in TDF resistance, but that also gives you cross-resistance to abacavir. The other issue in this case is that we did not have an HLA B5701 test available at the time, and we'd like to screen for that before starting people on abacavir. And then the fifth option, you don't know, actually may be a reasonable option. It's just going to take a few weeks to get the result back. But in this patient, if we had waited that long, he probably would have gone through all those Fiebig stages, and we would have missed the opportunity to treat him during acute infection and the benefits of very early treatment. So in this case, we did actually go for C. So this is question 5. So like I said, we did start him on AZT, 3TC, lopinavir. Now, given his history of tenofovir FTC use during acute infection, if we just have to guess, what do we think that his genotype result is going to come back? We're going to have to wait 2 to 4 weeks to see the result, but what do you think it's going to show? So here's our options. A is resistance to only the FTC, 3TC. B is resistance to the tenofovir only. C is resistance to both the tenofovir and FTC. D is no resistance, or E, I have no idea. So let's vote on this. So it looks like C is the most popular answer, but not the correct answer. So it actually turns out that A is the correct answer in this case, and I will show you why. Okay, so we actually have data from some of the clinical trials that have been done on people who are on PrEP and then become HIV infected during that time. So the first was the IPREC study. So this is a big study, about 2,500 MSM and transgender women in several countries, including the US, Thailand, and South America. And in that study, they had 38 infections in the group that was randomized to tenofovir 3TC. So it turns out that two of those people had HIV infection at baseline. So when they were started PrEP, they actually already had HIV infection, but they only knew in retrospect because they were able to do the NAT testing, but it wasn't done until later. But they could show that those two people in their baseline before starting PrEP already had HIV infection, and then when their serology became positive and they did a genotype, both of them had FTC resistance. And it turns out that the 36 people who they could show did not have HIV infection at baseline but became HIV infected during the course of the study, of those 36 people, actually none of them had FTC resistance, and then of those 38, actually none of them had TDF resistance as well. So you can ask, like, why is the resistance so low in the people who were randomized to TDF FTC? And really the reason was because they weren't taking the drug. So if you're not taking the drugs, you're not going to get resistance to it. So the reason that these people became HIV infected, even though they were given PrEP, is because they weren't taking the PrEP. As I told you before, in the IPREC study, it turns out that only about half the time people were actually taking the PrEP drug. But there's also been there was a meta-analysis from 46 published studies of over 10,000 PrEP users that was presented at the R4P conference in Madrid just a few months ago. So in that meta-analysis, they showed that there was 91 incident infections in these 10,000 people, and the vast majority of them, actually, they could get a history that they had stopped taking the PrEP drug before they became infected, or they were able to do hair or blood levels, and they could show that the people just weren't taking the drug. But they did have 49 people of these 91 that had genotypes done. And of these 49, you can see 11 or 22 had FTC resistance, and actually only one out of 49, so 2% had TDF resistance. So we can see from the people in the IPREC study who took PrEP, after they had HIV infection, or in this meta-analysis, that actually most of the time, people are not actually, the reason they get HIV is because they're not taking the PrEP medicine, and then they have no resistance at all. But if they are taking the PrEP medicine, the resistance to FTC will develop much earlier and faster than resistance to TDF. So usually if we're doing the HIV testing on a regular basis, and they don't have HIV infection for a long period of time before we do the HIV test and the genotype and switch them to ART, then it's more likely that they're going to have FTC resistance only and not resistance to TDF. It doesn't mean that we don't have to think about it as a possibility, because for our individual patient, we're not going to know until we get the genotype result. But most likely, we'll see FTC resistance, not TDF. Yeah, so this patient, as I said, we started him on AZT3TC lopinavir. He was stable without any symptoms. You can see at week 8, this is week 8 of ART, his viral load was undetectable, and CD4 count came up, and his CD4-CD8 ratio had reversed and become normal, which is more than 1 is normal. So we actually repeated his serology at week 12, and by that time his serology, everything had converted to positive. So in his antibody tests at that point, all generations, the 4th, 2nd, and 3rd generation antibody tests were all positive, and the Western blot had become positive at that time as well. And then we got the genotype result from him. So we can see actually he had one mutation in the NNRTI, which is M184V, and then for NNRTI he actually had 2 mutations, and then for the PI drugs he had none. So this is what you see if we plug those mutations into the Stanford database, this is what we get out. Yeah, so we can see that actually he does have high-level resistance to FTC and 3TC, but tenofovir was susceptible, no resistance to tenofovir as well. And then for the NNRTI drugs, he actually did have high-level resistance of efavirenz. So it was actually a good idea that we didn't put him on efavirenz at the beginning. So, how do we interpret these results? So the NNRTI resistance, so that had to have been transmitted. At the time we did the genotype, he had never had exposure to NNRTI drugs in his life, so there was no way for that resistance to be acquired. So when he acquired HIV, it had to have the NNRTI resistance already. Now, for the NRTI resistance is a little bit difficult to interpret. So it's possible that when he got the infection, he had the NRTI resistance already, and that might be responsible for why he became HIV infected, despite the fact that he was taking PrEP. But we didn't have a genotype test from before he started PrEP, or we didn't have a viral load before he started PrEP, so we cannot say for sure. So it's also a possibility that somehow we acquired HIV either before he started PrEP, or maybe when the first week or so when he started PrEP, and that the original virus was wild type, but then under pressure of the PrEP drug, he was on dual treatment for some period of time while he had HIV infection, that the NRTI resistance might have evolved after infection, and that we cannot say for sure. Given his history and the amount of time, it was 8 weeks from he started PrEP until the first antibody test was positive. I think he probably was infected with a virus that had the M184 mutation before transmission, because we know that the virus he got was resistant to NNRTI. If somebody's resistant to NNRTI for whatever reason, there's a high chance they're going to be resistant to NRTIs as well. But we cannot prove that. So the conclusions for this case, he acquired multi-drug resistant HIV infection while on PrEP. So either it was transmitted while on PrEP, or maybe in the first few days of PrEP use before PrEP had reached full efficacy. So we have to keep in mind, if we're starting a patient on ART who's newly diagnosed with HIV while they're taking PrEP, so the first thing you want to ask about adherence, because the vast majority of time you get a history that he wasn't taking PrEP, or had stopped PrEP, or something like that, or maybe was taken with not good adherence, and if you take less than 4 pills per week, the efficacy of the PrEP is going to be a lot less. If the patient, if you get the history of good adherence, then you need to consider the risk for transmitted or acquired resistance to FTC and or tenofovir. And if you're starting ART, you want to choose a regimen that's going to maintain efficacy in the presence of resistance to both of those drugs. In our case, it turns out he was only resistant to one, but we don't know that until we get the genotype. So I would recommend starting ART on a regimen that's going to be effective, even if there's resistance to TDF and FTC. So one thing you may be wondering, and we wondered a lot about this case when we first came, is if the virus he acquired was resistant to FTC but susceptible to TDF, why did he get HIV infection? Why did not the TDF then protect him from HIV infection? And that's a good question, and when this case came up, it's been a couple of years ago already, nobody had reported that was happening, that people were getting HIV infection while taking tenofovir. But actually it turns out since then that this is not the only case where that's happened. There's actually been 6 reported cases now in the literature, including our case from Pattaya, in which people were taking PrEP. They had both a history of good adherence, and either a hair sample or a blood sample could show through objective measures that the patient was taking the PrEP with good adherence, as they said, but yet the patient still became infected with HIV. So 4 of those cases were from North America, the 1 case from Amsterdam, and then our case from Pattaya, which is the only one so far in the developing world. But it's interesting to look, if we look at the sort of the red there on that column is the resistance profile. So the one, you know, and it turns out that you would think, well, everybody must have resistance to these drugs, but that's not the case. The first couple of cases that were reported did have resistance, but the third case that was reported was a case from Amsterdam, came out a couple of years ago, and that person actually, when they did the genotype, had wild-type virus. There was no resistance, but you know, well, the history that the patient gave was that he was taking PrEP with good adherence, and they did the biological samples to prove actually that he was taking the drug, but he still became HIV infected. Now it turns out that guy had literally hundreds of sexual partners per month for many months in advance, and almost none of it using condoms. So the thought is, and he also had STIs at the time. So the thought is that you know, for him, you know, maybe it was just so much exposure that if you get that much exposure, maybe PrEP, nothing is going to work if you just repeatedly expose yourself to that degree. But if you look at the other 5 cases, which had less exposure than him, actually, of those other 5 cases, 2 of them had a virus that was susceptible to TDF. So it was one of our case and the most recent case that was reported in San Francisco. The virus was resistant to FTC, but susceptible to TDF. And then the very first case at the top, which came from Canada, that person had mutations that gave resistance to FTC, and the mutations on the genotype actually gave low-level resistance to TDF. It wasn't very high-level resistance, and in that person, when they did a phenotype, so a phenotype is kind of like a culture, a viral culture for HIV, the phenotype actually showed that the virus was susceptible to TDF on the phenotype. So that virus seemed to be susceptible to TDF as well. So, you know, so something we're learning from these cases as they come up, it seems like that the in vitro methods we have to measure sensitivity to tenofovir does not necessarily tell us that PrEP is going to be efficacious against these viruses, and that it may be necessary to have sensitivity to both FTC and tenofovir to have full PrEP efficacy, and sensitive to tenofovir alone may not be enough for full PrEP efficacy. So we know that there's been studies of tenofovir-only PrEP. So, you know, now we have one PrEP regimen, it's TDF, FTC, but actually some of the studies that have been done have shown that tenofovir alone, without FTC, is effective for PrEP. But those studies actually were done in heterosexuals in the Partners PrEP study in Africa, and then the BTS study among people who inject drugs here in Bangkok. All of the efficacy studies of PrEP that have been done in MSM and transgender women have used the combination of TDF, FTC. So I think that, you know, that for MSM, at least we need to use both tenofovir and FTC together to get full efficacy of the PrEP. Okay, that's the end. Thank you.
Thank you, Dr. Donn. Excellent talk. Anyone who has questions? Nothing? None? But I have one. Is there any preferred regimen for those who don't have any resistance testing? For those who can't access genotype, do you have are there any guidelines on what needs to be started as preferred ART regimen for those who are taking PrEP?
Yeah, I don't know. I don't know of any guidelines currently, and you can see even in our case where we have genotype-resisting genotype testing available, it takes a while to get that result. So, you know, a month seems to be about average for getting those results back. So oftentimes we may decide to start ART in the absence of the genotype, even when we will get that in the future. But I think so two things. So I think, as I said, you know, the first is you want to take a history from the patient, a good history. And like I say, probably 90–95% of the time you're going to get a history that they weren't taking the PrEP. Either they had stopped it, Maybe they never started it or they stopped it. If they're not taking it, then they're not going to have resistance. Then you don't have to worry about it. But if they are taking the drug, and either you think that maybe they started the drug after they had HIV infection or the potential for HIV infection that was acquired while taking PrEP, then I think you just want to start a regimen that does not include TDF and is going to be effective even in the presence of both TDF and FDC resistance.
Okay. And then I have another question about this case had hair sample and he was taking PrEP with good levels.
Right.
How about patients who are taking intermittent PrEP? Would your management differ for those patients?
That's a good question because I think intermittent or on-demand PrEP, it's not in any of the guidelines yet, I don't think. But of course the data is out there and the studies show that it is effective and seems to be as effective as daily PrEP. So we might see more and more people on that. So obviously if you do the hair samples on intermittent, the hair samples will give you a number that's kind of an average of the last 6 weeks. So, and they're going to tell you it's consistent with, 7 doses a week or 4 to 5 doses or less than 2, something like that. And that's really going to then depend on how often they're actually taking it. But in terms of if somebody was taking PrEP intermittently, then I would approach it in terms of what I just said, in terms of how you think about what ART regimen to start, I would approach it exactly the same whether they're taking it intermittently or daily.
Okay. Thank you.
Okay, thank you.